Ahmedabad Medical Association has done a tremendous work. They have done it, and to give us the best of the knowledge to all of us. Now we are going to have a post-lunch session, minimal invasive cardiac surgery. Where does it stand today? Dr. Vishal Gupta, sir. Please go ahead.
Thank you very much. Greetings from EPIC. I'll be talking on minimally invasive cardiac surgery. Where do we stand today? Because there is a lot of hue and cry about keyhole surgery, minimally invasive surgery. With the advent of laparoscopic surgery in the field of GI and maybe minimally invasive surgeries in a lot of other specialities, people keep asking. We get a lot of patients who always come to our OPD and they ask, "Ke nana cheka mathi operation thai jai ki nahi?" So where do we stand as far as cardiac surgery is concerned with minimally invasive? This is what I'm going to talk in my subject. So what is minimally invasive surgery? So it is heart surgery performed from several small incisions instead of the traditional open heart surgery that requires a median sternotomy where the sternum central bone is cut in the middle and split into two and we do the surgery. So these are multiple other incisions in the thoracotomy, partial sternotomy, hemisternotomy. These are the various approaches that we use to do minimally invasive surgery. So as you can see from the slide, right now most of the intracardiac procedures that we do, they can be done by catheter-based interventions by the cardiologist or in a minimally invasive way, especially the valvular cases. But still, India as a country is lagging behind in minimally invasive cardiac surgery due to many reasons, mainly economic reasons, because the cost and the infrastructure of setting up a minimally invasive unit is extensive. And because of these yojanas like Ayushman Bharat, Mahamritam Yojana, it is becoming more and more difficult for more and more private setups to start such a program which requires a lot of financial constraint. As you can see from this slide, countries like Germany, West, where money is not a concern and everything is sponsored by the government, the number of minimally invasive cardiac surgeries that are being performed, especially in valvular heart surgery, the number is close, they range close to 50%. Whereas if you look in India, the number of surgeries which are performed in minimally invasive surgery still are around 4%. We have 3 times more the number of patients that are there in the West, but our minimally invasive numbers are 3 times lesser compared to the West. So as I said, these are the guiding forces. Now, as you can see from this slide, that in India, in valvular surgery, the number of surgeries that are performed in the year are this, and compared to that, only 4% are performed with the minimally invasive approach, especially also with congenital surgery and coronary artery surgery. So now how the cardiac surgery has evolved over the last 30-40 years from conventional median sternotomy to minimally invasive surgery. So this was the time of cardiac surgery when Sir C. Wharton Lillihei started cardiac surgery with controlled cross circulation, where the oxygenator function was being done by the parent of the child. If a child has an atrial septal defect or a ventricular septal defect, when there were no oxygenators, the parent's lungs used to serve as oxygenators. So, but the only risk was dual. It was not 100% risk. The risk was 200% because the parent was also sleeping on the adjoining table and he was acting as an oxygenator for the child. So in the earlier eras, when the cardiac surgery was being performed, these many number of people were there in the theaters, perfusionists, assistant surgeons, technicians. So from that era to now, we have come to a stage where there is robotic surgery, where just the surgeon is sitting in the console and all the robotic arms are working on the patient. So through multiple ports, various instruments and all these things are inserted and surgeries are being done by the robotic. It's done by robot, but it is the surgeon finally who is sitting and who is doing all the action with his hands and performing the surgery on the patient. So, so as you can see, here is the surgeon who is sitting on the console and with his dexterity and with his hand movements, he is performing a surgery on a patient which is far away. So now we need to understand what conventional surgical cardiac surgery is before we venture into minimally invasive cardiac surgery. The conventional cardiac surgery is a midline sternotomy where you cut the sternum bone from the center And this is how you institute the cardiopulmonary bypass for any patient which requires a intracardiac pathology to be dealt with, like valves or atrial septal defect or congenital abnormalities. So this, with these cannulas, you put the patient on heart-lung machine, and then you open the chambers of the heart and you do the desired procedure. You replace the valve, you repair the valve, you repair the defects which are there in the heart. And this is how the surgery looks at the end when we are about to close. And this is the end result in any conventional surgery. This is going to be the size of the scar with these drainage tubes. So now, what are the advantages of traditional approach? The advantages of traditional approach are, this approach has withstood the test of the time. All the surgeons that are getting trained in the country, they are most of the times they are government setups where the setups for minimally invasive cardiac surgeries are not there. So they are trained in the conventional technique first. Anyhow, even for laparoscopic surgery and GI surgery, they always tell that you need to be very well comfortable with the open technique before you venture into a laparoscopic technique, right? Because if anything goes wrong with laparoscopic technique, you should be very well versed with the open technique of doing the same procedure. So this is one of the biggest advantage. It has withstood the test of the time. Every surgeon is comfortable doing that procedure with that approach. It provides ideal operating conditions. You are in total control of the situation. You have the entire heart in front of you. If all of a sudden we operate on sick hearts, the heart fibrillates, there's some ventricular tachycardia, you need to defibrillate the heart. All these things can be done very comfortably in the traditional approach because you have access to the entire heart, right? It provides full access for procedures like coronary artery bypass surgery, valve surgery, intracardiac repairs of any congenital malformations, pericardial or other surgeries. So now, what are the disadvantages? Why people are trying to move from the traditional approach to minimally invasive approach? Whenever we cut the entire bone, we get a small cut on our finger, it will pain you for a couple of days. So you can imagine if we cut the entire sternum to do any type of cardiac surgery, it is going to give the patient pain, and that pain is going to be there for about 6 weeks to 3 months. This is what is the general time, but it also depends on individual threshold of pain. Some people are very strong. In 3-4 weeks, they feel absolutely all right. Some people who have pain threshold is very less, they may not become all right for up to 6 months to 1 year. So pain is one of the biggest factors which people keep come and asking for कि if we can do छोटे कट में से अगर ऑपरेशन हो जाए तो दे ऑलवेज फील के पेन कम होगा एंड दे विल बी एबल टू गेट बैक to their work and get back to their routine as early as possible. Of course, when you put a bigger cut, the amount of blood loss is definitely going to be more compared to a minimally invasive surgery. The healing time is longer. Patients generally take 4 to 6 weeks for the scars to heal, for the bone to join properly, and the patients can do their routine activities like they can drive their car, their two-wheelers, they can go to their work. People who are like into the labor type of work, they need to get back and start working with their hands. So for them, definitely it is going to take some time. And also there can be sternal wound complications because a lot of patients that we see these days are diabetics. As you know, that Gujarat is, especially Gujarat, is the diabetes capital of the world. The incidence of diabetes is increasing by the day. It has become a lifestyle disease. Similarly, most of the 90% of the cardiac surgery practices coronary bypass surgery. Valve is just 5 to 10%. So most of these patients are coronary bypass surgery patients who come to us, right? So, and these patients, out of these patients, 60 to 70% are diabetics. Obesity is very rampant. A lot of patients are very obese. Obese, females, diabetes, all these patients are risk factors for sternal wound infections. So these patients are likely to get into trouble, especially if proper care is not taken while doing the surgery. When you are harvesting the internal mammary arteries for bypass surgery, you need to clip the mammary just short of the lower end so that the vascularity of the sternum is maintained. It is only now, especially in the era where we have started doing a lot of bilateral internal mammary arteries for bypass surgery, it is very important that you try and preserve the vascularity of the sternum. Otherwise, these patients can get into sternal wound problem. And let me tell you, any patient after any surgery, however good or best surgery if you have performed, but if the patient gets into problem with the wound, everything goes down the drain. Everybody will forget કે અંદર bypass તો સારું થયું છે, એક વખત ટાંકામાંથી પાણી નીકળે, they are very upset, right? Because they have to keep coming for dressings, they have to be on regular follow-up. So this is something which is little painful when you do a conventional sternotomy. And also for some, it is cosmetically not very appealing when you have an entire cut. So these are the reasons why minimally invasive came into practice. I'll not get into details of minimally invasive cardiac surgery. These are how minimally invasive surgeries is being done with a 10 to 12 centimeters incision. It's a direct vision minimally invasive where you cut open on the side and the surgeon can see the chambers of the heart and perform surgery. The second would be direct vision video assisted. The incision goes down almost by 50% where you insert a couple of cameras into the chest and you do surgery looking at the screen and under direct vision also. The third would be video assist directed and robotic assisted, and fourth would be entire robotic as I showed. So here you can really bring down the size of the cut to a significant level. You can go down to 3 or 4 centimeters to do the surgery, but that again requires a lot of skill. The learning curve is very steep. The investments in procedures, if you want to do a robotic cardiac surgery and if you want to get a robotic unit in your hospital, the cost of robotic unit Da Vinci, which is the most commonly used robotic unit for minimally invasive cardiac surgery, is to the tune of 15 crores. So you can imagine the amount of investment, primary investment the hospital requires, and the equipment that is being used, the instruments that are being used to do minimally invasive surgery, they are all it's a very expensive affair to start a program. That is why when you see the numbers in India compared to the West, our numbers are very low. These are the primary reasons why still minimally invasive surgery has not picked up to a great extent in this part of the world. So these are the various incisions. You can see this is left thoracotomy. This is for coronary surgery. This is partial sternotomy, which is required for aortic valve replacement. This is lower hemisternotomy for any pericardial window, and the right-sided incisions are for any pathologies on the right side of the heart, that is tricuspid valve repair, mitral valve replacement, atrial septal defects. All these things can be done from the right-sided approaches. So the advances in minimally invasive surgery have happened mainly because of the availability of transesophageal echo. Right now, transesophageal echo has become an integral part of any cardiac surgical operation theater. We are getting so much of help, and all these echoes are being done by our anesthetists. Transesophageal echo is something which not many cardiologists do. There are some who by choice do, but most of the times, because this is done in the theater, our anesthetists, they get trained to do this type of transesophageal echocardiography, and they guide us. Whenever you are doing a minimally invasive cardiac surgery, you have to put the patient on heart-lung machine on the cardiopulmonary bypass by cannulating the femoral arteries and veins. So this transesophageal echocardiography, it guides us whether the cannulas are placed properly, the cannulas are in the right position. So with this transesophageal echocardiography, things with my minimally invasive cardiac surgery definitely have become better. And these and other things are these smaller cannulas, negative venous drainage, instruments with long fine tools, endoscopes. All these things have started making minimally invasive cardiac surgery little approachable and reachable for people. So which are the various surgeries that can be performed? So from right-sided heart, right-sided thoracotomy, on the right side incision on the right side of the rib spreading incision, you can do mitral valve surgery, tricuspid valve surgery,
1 minute left,
ASD closures.
1 minute, sir.
Okay, so I'll just get into details. So the advantages are it is cosmetically better, less pain, less blood loss, rapid wound healing. Disadvantages, as I said, it's technically demanding, lot of training, expensive. Contraindications are very obese patients, patients with previous lung surgery, severe LV dysfunction. So these are the various instruments. I will not get into details. So these are the things. So what are the surgeries that can be done with minimally invasive? Aortic valve, mitral valve, coronary, but coronary with a pinch of salt, because the patients that we get, they are not amenable to minimally invasive. Patients come very young with extensive disease which cannot be addressed with minimally invasive. So these are the various incisions. This is how a minimally invasive aortic valve would look. And this is the incision after surgery in a patient with aortic valve replacement. Similarly, these are the incisions. This is how it looks after minimally invasive mitral valve. This is an atrial septal defect closed with a minimally invasive right thoracotomy. This is a minimally invasive CABG incision. You can see a small cut in the inframammary space. And this is how you put an octopus, which is a stabilizing device to do a coronary anastomosis. This is how an anastomosis looks at the end. But with CABG, because 90% of cardiac surgery work is coronary artery disease, I would like to tell you the limitation of minimally invasive cardiac surgery with CABG is you cannot graft more than 2 arteries. Anastomotic site occlusion was very frequent because coronary artery surgery, unlike valve surgery, is a very fine work. You are doing anastomosis on a 1.5 to 2 millimeter artery and it's an extreme fine work, and you try to do it with long instruments. The anastomosis is not good and patients, they get into trouble. We keep doing a lot of redo surgeries for patients who have undergone previous minimally invasive cardiac surgery. So cardiac surgery is a difficult option. So contraindications to minimally invasive would be small target vessels, calcific vessels, diffusely diseased target vessels. You look at these angiographies, multiple blocks. This is what the patients come to us. Each artery would have 3 or 4 blocks. So in all, patients would require 6 or 7 bypasses. 5 is the minimum that we put in majority of the patients. So you can imagine when you are trying to do this with minimally invasive technique, you end up doing a compromising work. So a normal peculiar Indian, I would tell you, is a young person, because these days we operate on patients as young as 35 to 40. Patients have high rate of 3 vessel disease. They have diffuse involvement, the distal disease, and there is a lot of bifurcation disease. And as I said, prevalence of diabetes mellitus, small coronary vessels, strong family history. So these are the patients you really have to think whether you have to subject them to a minimally invasive technique or not. So my take home message would be isolated valve diseases. Patient needs an aortic valve replacement, mitral valve replacement, atrial septal defects. These are the cases which are best suited for minimally invasive, and people have got reasonable expertise to perform these. But in CABGs, mix should not be at the cost of number of arterial grafts. It should not be at the cost of complete revascularization. A patient who needs 5 bypasses because of minimally invasive technique, if he gets 1 or 2, that is not serving the purpose, because he has come to you for complete revascularization. That is what differentiates surgery from PTCA. If you are going to put 1 or 2 bypasses, might as well subject him to a angioplasty. They would open 1 or 2 arteries. Patients come to you, patients come to surgeon with diffuse involvement, multivessel disease, because they want complete revascularization. That is what is going to keep them disease free for years together. So coronary artery disease, minimal invasive, we still at our center, only patient if he has a single vessel disease which cannot be stented, we subject them 1 or 2 bypasses, we subject them to minimally invasive technique. Otherwise, you do total arterial, put 5-6 grafts, these patients will be all right for years to come. So you cannot do minimally invasive at the cost of safety, efficacy, and durability of the procedure. Thank you very much.
Thank you, sir. Thank you.
No, that's it.
Thank you, Dr. Vishal Gupta, sir. It was just fantastic. And diabetes is very common. It's very common. All of us are getting a lot of diabetes patients. And